welcome to our series of pediatric lessons, and today we are looking at chickenpox as usual. I'm your presenter, John. So chickenpox is an acute viral infectious disease, and its common name is varicella zoster. It is an extremely contagious disease and is usually sometimes mild, but in some cases it can cause severe pneumonia or birth defects in an unborn child if an expected woman is exposed in the first 3 months of her pregnancy. So what we are saying here is that chickenpox is an acute respiratory disease, and its common name is varicella zoster, which is derived from its causative organism. So it is extremely contagious disease, and usually may be mild, but in some cases it may cause severe pneumonia or birth defect in an unborn child if the expectant woman is exposed within the first 3 months of her pregnancy. So chickenpox is caused by the varicella zoster virus, also known as human herpes virus. It is a DNA virus and a member of herpes virus group. So primary infection results in varicella. So this is a recurrent infection which results in herpes zoster or shingles. So I've tried to attach a diagram which is showing a child who has chickenpox and the type of lesion or varicella lesions that you can see. So infection in pregnancy and childhood. So what it is that antibodies are produced as a result of immunization or previous infection are transferred via the placenta to the fetus. So immunized women can not become infected, neither can they infect their unborn baby. So varicella infection in pregnant women can lead to viral transmission, that is via placenta, and infection of the fetus. If infection occurs during the first 28 weeks of gestation, this may lead to fetal varicella syndrome. So what are the possible problems that may be due to exposure in utero? So the possible problems may include damage to the brain. So the damage to the brain, the gravity is that the child may have encephalitis or may have microcephaly, hydrocephaly, aplasia of the brain. Other possible problems due to exposure in utero include damage to the eye, leading to optic stalk or cap and lens vesicles, cataract or chorioretinitis. Optic atrophy can also be seen. Other neurological disorders include damage to cervical and lumbar sacrospinal cords, motor sensory deficits, and absent deep tendon reflexes. You also have to notice that within this condition, other possible problems due to exposure in utero may include damage to the body, that is, there may be hypoplasia of upper, lower extremity, anal and bladder sphincter dysfunction. Of course, skin disorders like skin lesions and hypopigmentation can also be seen. Now, neonatal varicella. Maternal infection is associated with premature delivery. The risk of the baby developing the disease is greatest following exposure to infection in the period 7 days prior to delivery and up to 7 days following birth. The baby may also be exposed to the varicella via infectious siblings or other contacts if not immune. Newborns who develop symptoms are at high risk of pneumonia and other serious complications of the disease. Let's now look at mode of transmission. So mode of transmission is through direct contacts, that is with patient who sheds the virus from vesicles or indirect contact through articles freshly sold by discharge from infected persons, or it may be through airborne or spread by droplet infection. So scabs are not infective. So the period of communicability, the patient is contagious about a day before the eruption of rashes and continues to be so up to the 5th or 6th day after the last scab formation, or until all vesicles have become encrusted. So we are saying the patient is contagious about a day before the eruption or rashes, and before the eruption of the rashes, and continues to be so up to the 5th or 6th day after the last scab of formation, until all vesicles have become encrusted. So let's look at pathogenesis, and the incubation period for this disease is about 7 to 23 days. So let's look at the pathogenesis according to the number of days of what is happening from day 1 to 3, day 4 to 6, day 10 to 12, and then day 14. So day 1 to 3, there is infection of the conjunctiva or mucosa of the upper respiratory tract. So this allows for viral replication in the legional lymph nodes. Day 4 to day 6, there is primary viremia, so viral replication in the liver, spleen, and the other organs. Day 10 to day 12, there will be secondary viremia. That is, secondary viremia is characterized by diffuse viral invasion of capillary endothelial cells and the epidermis. And then on day 14, we see the infection of the skin and appearance of vascular rash, or the varicella rash. Infection of the cells of the malphigian layer produces both intercellular edema and intracellular edema. So pathogenesis and the sequelae of the disease. So exposure to varicella infection in a healthy child initiates the production of host immunoglobulin G, immunoglobulin M, and immunoglobulin A antibodies. So immunoglobulin G antibodies persist for life and confer immunity. Cell-mediated immune responses are also important in limiting scope and the duration of primary varicella. After primary infection, varicella virus is hypothesized to spread from mucosal and epidermal lesion to local sensory nerves. Of course, that is just a hypothesis. Otherwise, then this disease may remain latent in the dorsal ganglion cells of the sensory nerves. The activation of the varicella may result in the clinical distinct syndrome of herpes zoster or shingles. Let's now look at the clinical picture. So there can be mild prodrome fever, malaise, headache, backache, and sore throat. This may happen from 1 to 2 days. Then successive clumps of paralytic lesions can be seen 2 to 4 days, and generally they will appear first on the head, mostly concentrated on the trunk. They can spread over the entire body, causing between 250 to 500 itchy blisters. So generally they are mild in healthy children, but for those who might be immunocompromised, they may not be mild, they may become extensive. So the child may also develop diarrhea and vomiting that may lead to dehydration. Alright, so the stages of chickenpox otherwise from the incubation period of 7 to 23 days is that for 1 to 3 days we have prodromal signs and symptoms, and then we will be able to see the vesicles, then we see the pustules, then the scales. Recovery may be 7 days after the rash appearance, okay, or 5 to 35 days. Characteristics of the lesions. So they may last for about a week. Papules and vesicles develops into pustules, which then crust over prior to healing. The development of several crops of spots, a prominent feature of chickenpox, may also be seen in the patient. I'm going to attach a photo, or there'll be a photo that you're going to see on what I necessarily mean on the same clinical picture. So the development of several crops of spots, a prominent feature of chickenpox, and at the peak of the illness, 3 to 4 days, there are lesions at all stages of development, from new vesicles throughout the crust. So from this diagram, you are able to see the blisters. That is, we are showing the blisters, and then the red spots, and then the hard crust when the chickenpox is drying up. So the blisters, the way they will show as if someone was burnt, but small blisters, like a blister for burning. Okay, so we can move on. So herpes zoster. So the activation of varicella zoster virus is associated with herpes zoster. That's what we said. So this can be associated with aging, immunosuppression, or intrauterine exposure, or varicella that is due with 8 months age there and the likes. So complications. Secondary bacterial infection of the lesion. Since the integrity of the skin has been compromised, we may see bacterial infection of the lesion. Other complications: disseminated primary varicella infection in immunosuppression, such as pneumonia, myocarditis, hepatitis, and glomerulonephritis, are some of the complications that can be seen in those that are immunosuppressed. So we can also see central nervous system manifestation, okay, like encephalitis, acute cerebral ataxia can also be seen. Blood complications or disorder complications to do with blood include thrombocytopenia, and we may also see other complications like papular secondary to varicella infection. Pneumonia, though rare in children, and septicemia and osteomyelitis can also be seen as some of the complications. So now we can talk about treatment. So treatment for this disease is symptomatic. So you have to treat the itches, that is, clip the patient's fingernails, short, and encourage frequent hand washing. Apply antihistamine or soothing skin lotion such as calamine in order to reduce on the itching. For fever, you can give an antipyretic, and acyclovir as an antiviral drug can be given per oral, that is 800 milligrams 3 times a day for 5 days in pregnant women or elder children above 18 months if they have severe infection. Prevention. So it is gratifying to know that there is vaccination for this disease. So 2 doses separated by 4 to 8 weeks, not to be given to pregnant women and the sick, but effective within 72 hours of exposure. It's important that the vaccination is given. Then isolation of infected patients can help also in the prevention. Wearing of gloves to perform dressing changes or change the bed linen or when in direct contact with the patient is also important, because the fomites may act as a vehicle for infection. So you can wear a mask or have the patient wear a mask to prevent respiratory spread or the spread of a droplet infection to the surfaces. So how can this disease be diagnosed? So there should be determination of varicella virus, okay, through that is a complement fixation test, and determination of varicella virus through electron microscopic examination of vascular fluids can also be done. So let's now look at the nursing care as the last component for this condition. So prevention of secondary infection of the skin region through hygienic care of the patient is important so that the lesions can heal fast. Then you should also give attention to nasopharyngeal discharges and disinfection of clothes and linen by sunlight or boiling, so that they do not act as a vehicle for spreading of infection. So you can also cut fingernails and encourage hand washing more often in order to minimize bacterial infection. And you have to know that through scratches, the infection is introduced in the nails. So that's why we are sharpening the nails. So calamine lotion over rashes can be applied, and antibiotics for patients with fever can be given. Isolation of the patient is important until all lesions have become infested or they have exposed on them. The use of protective equipment like apron and mask is encouraged in this condition. So there you have it. We are looking at chickenpox today, and this is in our series of looking at the pediatric condition. If you have any questions, please you can get back to us through our Google class, and we'll be able to explain everything. So thank you very much.